Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Cherokee Health Systems for hosting today's session, Medication Non-Adherence, Part 1, Dr. Fred Kleinsinger. Dr. Kleinsinger is an Associate Clinical Professor, Family and Community Medicine at the UCSF School of Medicine. He retired after practicing medicine for 38 years. Although he initially practiced at community medicine clinics and in a private practice for 5 years, for the last 13 years of his practice, he was a physician in the medicine department at the Kansas Oakland Medical Center in Oakland, California, where he was an assistant chief of medicine. At Kaiser Oakland, he developed and administered the mentoring program for new medicine department physicians. He also was involved in introducing the electronic health record to the medicine department physicians. Since retirement, he has been active teaching first through third-year medical students at UCSF. He also has developed and led CME workshops on a variety of topics at regional hospitals throughout the state of California. He has published 3 articles on the topic of medication non-adherence, which is a special interest of his. Dr. Kleinsinger, it's all yours.
Okay, well, hello everybody. I'm delighted to see from the number count that you're all here today. In some ways, I wish this was the old days in which we'd all be in a room together, but for a number of reasons that isn't happening. I just want to echo what Jennifer was saying. I'd like to do interaction with Zoom. I know it's difficult, so hand raising, chat. I'm interested in questions, comments, disagreements, whatever, because I think that makes I do a better job, and B, I think you feel that I'm more responding to who you are and what your own individual circumstances are. Now, before I actually start, I'm just curious, can someone tell me what is Cherokee Health Services? Are you all in an integrated system? Do you have one particular group of patients? Can someone just tell me a little bit about that? So anything I can tailor to that, I will. You're a federally qualified health center. Okay. Does the name Cherokee mean that you mostly take care of people, not Native Americans and the Cherokee tribe, or is that, is there a consistent cultural, group who use your services? Okay, all nationalities. Okay, great. Thank you very much for that. Anyhow, disclosures, I have basically, nothing to disclose. I don't have any conflicts of interest with this, etc. And as Jennifer is saying, this is accredited for CME. Okay, beginning the actual presentation, medication non-adherence. Is this, as is usually thought within the medical profession, an aberration in the usually very, very smoothly functioning treatment process, or is it an extremely common outcome in treatment of chronic diseases? Many chronic diseases. I use the examples of hypertension, diabetes, and dyslipidemia because they're so incredibly common. But I'll come to this later on. People have asked me in questions when I do this presentation, well, what about symptomatic conditions? That, does that have any effect? And the answer is usually not, but we'll come back to that. The goals of this presentation: we want to talk about the frequency and consequences of medication non-adherence, some about causes of non-adherence, and then about diagnosing. How do you as a clinician become aware of non-adherence? Oh, speaking of clinicians, I use a lot of synonyms for clinicians. I sometimes use the word doctor out of old habit, though I realize that many of the people I'm talking to are advanced, nurse practitioners, physician assistants. So please, if I slip and use the word that, I mean all of you. And I try and avoid the word provider. I don't like that. That makes me feel like I'm some widget in an insurance company's ledger or whatever. Okay. So next week, same time, same place, we're going to have a second session, which I consider to be even more important than this one, about, so how do you're aware of the problem of non-adherence. What can you individually or collectively do to improve non-adherence? That will be the topic of that one. So I encourage anybody who finds this topic interesting and intriguing or wants to talk about the practical aspects of this to come back if you can. Okay, So if we define compliance as taking 80% or more of one's medication doses, that's extremely common in the literature. What percentage of patients succeed in meeting this target based upon a recent meta-analysis? Does anybody want to hazard a guess? Well, I put it in. Okay, I'm reading some of the old stuff. Greater learner. Also, mostly Latino immigrants, non-adherence is the best term for charting rather than not. Okay, someone's asking about non-compliance. I use compliance here. The term in the last 10, 15 years has changed from compliance to adherence. The main reason for that is that compliance has an authoritarian ring to it, and it's based upon the old model of I am the doctor. I will, give you doctor's orders or recommendations, and you will comply with my recommendations. I know that you don't mean it when you do that, but that sort of has that feeling to it. Adherence sounds a little more neutral, and it also goes along with what my belief is, which is that the doctor-patient, the provider-patient, the patient, whatever relationship is an active and dynamic one, not a one-way, I am the authority and you are the lesser human being who will do what I tell you to do. And I'm exaggerating when I say that, but in my experience, which is fairly widespread, there's still, that attitude still is in the background in many medical encounters. Okay, 60%. This goes across the board. In some studies, it's 50%. And where the studies in which this was based are usually with insured populations. So the issue of poor access to medical care is not the biggest one in terms of the studies that show these very poor adherence rates. And also, the other aspect of that is that this has changed since I first started giving this presentation. I have usually said cost is an issue, and we'll talk about that. But for hypertension, for example, virtually every medication being prescribed these now is generic and low cost. However, for diabetes, that's changed with the era of the GLP-1 agonists and the SGLT2 inhibitors, which are all very expensive. So cost actually has become a very major issue, but it hasn't changed things a whole lot. So 60%, 40% of the people you are seeing are probably not taking medications either correctly or at all. So in a given day, you're seeing 10 patients with chronic conditions, that part of the focus of it. It's very likely that 4 of them are not taking their medications particularly well. So this is an extremely common problem. Okay, so background. So more about non-adherence. Prescriptions never filled. You hand it to the patient or you put it on the computer, whatever. 20 to 30% don't ever fill the prescriptions. Medications not continued, around 50%. By the way, I'm going to come back to this. This is an old study. Modern studies are no change. So the rates of medication adherence drop in the first 6 months. Only 51% of Americans treated for hypertension are adherent to long-term therapy. And when you look in a slightly different way at community control rates from a public health perspective of hypertension, for some bizarre reason, about 50% of patients diagnosed with hypertension have good control. Now, could those two factors be related? Looking at statins, 25 to 50% of patients discontinue statins within 1 year of treatment initiation. And as I mentioned quickly, what about symptomatic conditions like coronary disease? In one study of people who were admitted to the hospital with heart attacks, within the first year, 12% of patients stopped all 3 of the commonly prescribed medications within a month, and this particular group who'd stopped their medications had a significantly lower 88.5% 1-year survival compared to 97 point. So there's a hazard ratio of death of over 10% in stopping those medications in the first year. Yet people do that. And this is true even for conditions that are consistently symptomatic. For example, if you look at COPD or asthma, which tend to be symptomatic, many people do not take their medications well. You all know, I'm sure, that asthmatics who they've been prescribed, a controller, they've been prescribed the medication for, bolus use, and they don't use the controller. And so adherence rates remain low. I was asked at the previous time I talked this about mental health diagnoses, that's even worse for a whole lot of reasons, but including the fact that people with significant mental illnesses sometimes don't take the best care of themselves. But even though that's symptomatic, they don't. So this is a universal problem. And now this slide you have to take with a grain of salt or a pound of salt, okay? Even though I just saw these numbers quoted in the literature, an article that was written last year, but this is older. But someone extrapolated from the data they had and decided that there are 125,000 deaths per year in the United States for medication non-adherence, people who had diagnoses that could be treated successfully but weren't because they weren't taking their medications. And if this were true, it would become the 6th leading cause of death in the United States. Now, that may not be right. It may be the 8th leading cause, it may be the 10th leading cause, but the big point is that this is a major, major problem, and it's not just one of statistics and numbers, oh, they don't take their medicines, but it has real life consequences to them and their families. And also, I'm not putting the numbers in here, the public health system, billions of dollars of extra costs for people whose conditions are not controlled well and end up in the hospital or worse because of not treating their chronic conditions well. Now, some of why this might be, advocacy organizations. Well, we all know about the American Heart Association, Cancer Society, Lung Association. But to the best of my knowledge, there's no American Medication Non-Adherence Association, even though the consequences and deaths related to this are as major as is often found in some of those other conditions, entities that were described above. In other words, medication non-adherence, it's an orphan problem. No entities, to my knowledge, have taken this on in a serious fashion. And this is counterintuitive to me. I can sort of understand why drug companies don't. One of the reasons drug companies don't is that many of the medications that we talk about when we're talking about treatment of hypertension, for example, or arthritis, are generic, and so Big Pharma doesn't make any money out of a $10 prescription for hydrochlorothiazide. But even you would think that the insurance companies, because they're losing money on this, would take this on. Hospitals would take it on. It's complicated, but it is an orphan problem. That one of the reasons for that is that doctors are unaware of this and resistant to seeing that we practitioners have a major role here, because let's face it, this is not covered in our training particularly well, and it's not covered in CME, this particular class notwithstanding, particularly well. And so it's not an obvious kind of thing. You have to look for it to see that it's actually happening, because the patients don't bring it up, because for a whole lot of reasons, including embarrassment. Now, and you would really think that insurance companies, because they're losing tons of money on this, would take this on, but it hasn't happened much. And I've been researching and writing about this now for somewhat over 20 years, and very little has changed about this. Every few months I go back into the literature and see what people are doing or saying, and the adherence rates continue to be changed, very low. People tend to raise alarms about this without having any concrete plans of action, and most practitioners are unaware of the scope and magnitude of this problem and its many negative consequences. So it's an orphan problem, and that's a shame, because it's an orphan problem that has consequences to many of us. Now, there is more attention in the literature now. The volume of publications on this topic have increased significantly in the last few years, but they're mostly like raising alarm, or they're still staying with the old blame the patient thing, which we'll talk about. It's their fault, it's not our fault, why do you think we're responsible, etc., etc. So anyhow, it's a problem which is largely ignored, and it's really a shame. So a question for you all. What are some of the factors in your own belief or practice that you think are causing these low adherence rates? Does anybody want to put that in the chat or raise their hand? Cost, uneducated. Yes. Both are absolutely true. Don't know why they're taking it. Yay! This is really one of the most important things here. Don't know why they're taking it. We're going to come back to that in some length. Health literacy problems. Yep. And also health literacy is a universal problem, but it's in my experience in federally qualified health centers and safety net clinics, it's particularly a problem because people have lower educational levels and lower socioeconomic standing, not understanding the purpose. Language barriers, low health literature is absolutely all correct. Transportation barriers to getting refills, yes, there are all sorts of difficulties. Not understanding the importance of the meds or consequences, absolutely. To me, this is the most important thing. We're going to come back to this, but since one of you has raised this, Nita, this is probably the most important part. If people really knew why, understood, grokked, to use an old term, why we're prescribing them hypertension medicines, why it's important to get their A1Cs down, they'd be more motivated to do it. But we as a profession are doing a relatively poor job, in my opinion, in many people's opinion, of getting that through to people in a way that can really impact them. BID or TID medicines, absolutely right. TID, anyone who prescribes a prescription medicine TID and for a long term and expects that the patient is going to take that is probably not right unless the patient has obsessive compulsive disorder. But people do not do that. And sliding scale rapidly acting insulin, that is so hard. It's hard enough to get people to take insulin in the first place, but when they have to check their sugars or use a CGM, and it gets complicated, and then we get into our low health literacy aspects too, and also that insulin is a dangerous drug in many ways. Short time with patients, need more ancillary staff. Absolutely. Look, I mean, you are, this is the best set of answers I've ever had to this question, and I've given this presentation many times. So you are really tuned in here. I'm delighted to see it, and we're going to come back to some of those things. Our pharmacists are amazing. Good. We're going to talk about that, particularly next time. The fact that the responsibility for dealing with this does not just fall on the individual clinician, at least successfully. And the pharmacists and other people can have time with this, really focus on adherence. Absolutely. We have so many things we have to talk about. And it's not the topic of this particular presentation, but there isn't enough time in the day for the primary care clinician to do their job. This is universally understood, if not particularly appreciated or done anything about. But yes. And the price, misunderstanding about why they're taking, yes. Absolutely. Okay, so you have done a great job here in these things. I'm just going to run through. I have my own list that you have largely anticipated. And we're going to... Okay, so factors affecting adherence, as I say. Motivation. Well, several of you brought up the whole issue of motivation, and motivation is a subset of education. People are motivated if they understand, if they've been given good information about why this is important. Why do we think this is important? Convey that to them. Cost, absolutely, especially in federally qualified health centers. Time, you've already brought that up. Alternate belief systems, this is a big one in some cultures where people are not really enamored of Western medicine. We'll talk about that. Treatment of asymptomatic disease. As I said before, this is relevant, but even symptomatic disease is not that great. Poor provider-patient relationship. Yes, there are some reasonably good studies showing that with patients are less happy with their clinicians, that they're less likely to do what he or she are recommending. Inconvenience. And then a few specific factors. We're going to talk about depression, denial, cognitive impairment, drug or alcohol use. These all affect things. Complexity of treatment, the more complex the treatment, the harder it is for people to do. Side effects, one of you brought that up. And when I talk about side effects, it's really important. I think that there's a related issue, which is even more important than side effects, and that's fear of side effects. Many patients won't even start a medicine, and if you finally can find out why, they say, well, my next door neighbor, I showed him this prescription for lisinopril. He said, oh, you shouldn't take that. My lips started swelling. It was terrible. I mean, people are hearing this kind of thing all the time. And if it's not their next door neighbor, it's the incredible wealth of 100% accurate information that they're finding on the internet. That's doing that too. But we have to be really aware of side effects and fear of side effects. Cultural issues, which we're going to come back to. But this particular, I'm I put this long slide in about what are some of the obstacles to adherence, and at the same time saying, yes, we should be aware of them, but no, those are not the most important factors here. Because the most important factors you all have correctly identified, it's education, motivation, having patients understand in a way that is meaningful to them why we're prescribing this, what their benefit's going to be. But taking a step backward about any kind of behavioral change, inertia rules. We human beings tend to move in a straight line and only divert with major factors inducing us to do this. Changing human behavior is difficult. And by the way, this talk is about medication non-adherence, but we as clinicians want our patients to do a lot of things besides medication that we could use the term adherence for. We want them to eat more healthful, we want them to exercise, we want them to stop smoking. All these behavioral changes are difficult, as I know that you know from having either worked on it with your patients or we're all human too. Many of us have tried various things ourselves. So there are a lot of the studies in the literature are focusing on what's called barriers to adherence, which is some of the things we're talking about. And a lot of them sort of say, well, if we didn't have all these barriers, which aren't our fault as clinicians, we can't help the fact that it's inconvenient, that it's difficult, that people can't afford it, etc. So that's on them. And that various obstacles can potentially interfere with this process. But that's still back in the old days. A newer understanding is that change is an active process. Active process, a continually active process. It's not just a one moment, oh, I'll do this. It's an active process. And the success requires education, understanding, motivation. Those three are closely related together because motivation is a subset of education and understanding. The old patients will take the medications because I have prescribed it for them and I'm a doctor or I'm a nurse practitioner and I've given them a brief 2-minute explanation. You have high blood pressure. Don't you know that if you have high blood pressure and the pressure stays high, that can increase your risk of heart attack, stroke, kidney disease, and even sudden death? Good news, if you take these pills once a day, that's much less likely. Any questions? No. Okay, here's your prescription. Now, okay, I know that's a little bit of a exaggeration, but there's still a lot of truth in that. Education, understanding, motivation. We're going to talk more about that in the second talk in this. How do we achieve that? Tools, we've helped patients with tools for how they want to do what they want to do. We work about the constructive steps they can take. And then the last 2 steps are monitoring and evaluation, in which we keep track of how they're doing and how both individually and as a group and for all the patients in our clinic, and then feedback to the practitioners and to the patients. All these things are important to achieve success. Now, this is just a voluntary question talking about the difficulty of health behavior changes. Have any of you want to volunteer anything about any difficulty you might have had about taking on some health change that you either was recommended to you or you decided to take on yourself? What was hard about it? Okay, well, and feel free to put that into the chat if you want to share that. But it just, in my experience, not having the time to practice the change. Yep. Hand raised. Changing my routine to accommodate. Yep. And often a big change. Someone disagreeing with the clinician's orders. Ooh, that's a really good one. And we people who with a lot of health education often will disagree. Change your daily routine is really hard. Time issues, yes. Too busy, don't have time. Absolutely. Or have circumstances that in people's life circumstances just make it hard to change. When I was working in East Oakland many years ago at a community clinic there, one of my big things was exercise. And a lot of the patients would sort of, they'd nod their head, but then that was it. And so when I got better about that, I said, how about taking a walk in your neighborhood? And finally, people said to me, Doctor, it's not safe to walk in my neighborhood. I don't go out of the house except, to go somewhere. Issues that you get if you have time, would love to unmute and speak. Okay. Resistance, knowing that change is a likelihood, even though we present it as always successful. Yeah. Um, LB, can Jennifer, can you unmute LB so that they can speak?
Sure, let me get to that. Hey, Lena.
Hi, thank you so much, so much. I guess that's just bringing up a lot in me. It's just over time working with the underserved, I've started to become really humble that like I really have no idea what my patients are going through. It's like some of them they have a list by the nutritionist. Lunch was one piece of cheese, and then these single moms and all that. So I think that I have to be careful about having expectations and asking them to do things that they just can't given their circumstances, because all that does is create more stress. And I know as a doctor, right, if I'm being told to do all like lots and lots of things in one visit by my boss, but I literally can't because all they're doing is giving me 15 minutes, it just creates like an inner disharmony that's really stressful. Does that make sense?
Absolutely makes sense. And there's a really key issue there. If we don't understand our patients' life circumstances, it's really hard for us to put ourselves in their shoes and to help them overcome whatever difficulties or obstacles that they personally are encountering. And again, we in the second talk, that a lot of that's going to be about mutual interaction. And I'll give you a little hint about my best suggestion for a communication tool for all practitioners, and that's what we call the mouth zipper. And by that, I mean we talk too much and we don't listen enough. So, and when I say that, I know that many of you are thinking, yeah. I'm 20 minutes behind. I've got 4 patients waiting to see me. I've got 3 problems to deal with this patient. What am I going to do? And I'm not going to say this is easy. Yes, absolutely. So, in other words, we as a profession underestimate the difficulty of making changes. And if you look at it in your own life, if you look at it in regard to your patients or your family members or friends, you see that this is a really major problem. Now, another question for the group. How do we as clinicians assess adherence? I'm open to any responses. Anybody have anything? Oh, chat. Okay. I'm going to look at the responses. I was in the wrong field. Denial about chronic conditions, either severity or immediacy, fear of side effects. Oh, I said that already. They cannot. Resistance, knowing that change is a likelihood, even though we present it as always successful. What do I know as a single mom about a single mom's life? How often do you miss doses of medicine? Great question. Asking patients, I'll talk about that. Medication lists, seeing results, checking with pharmacy, call pharmacy, looking at numbers, ER visits, A1Cs, BPs. Yep, great. If you have insurance companies that notify you, that's great. It is certainly not universally happening, and it would be great if it did. Patient says they're taking medicines, don't reflect that. I check with pharmacy. Okay, these are all great answers. I'm going to go through my list, but I'm really pleased you really have been thinking about this. 2 main principles. Always be alert to the possibility of non-adherence. At any given day, you're seeing patients who are non-adherent to chronic condition medications. Ask open-ended, non-judgmental questions about adherence. We tend to here compare and contrast these 2 different questions. You take all your medicines, right? Yeah, okay, good. By the way, in this and other presentations, I'm going to be giving slightly exaggerated bad answers, and all those bad answers came from me, from my own practice over the years, mistakes I've made, in which I like being perfunctory about this. Versus, in an average week, how many doses of your medicine do you actually miss taking? Now, what's good about that framework is a number of things. Okay, one, it normalizes this. You could say, as about a lot of difficult questions, a lot of my patients have difficulty taking medications regularly for a whole lot of reasons. I'm curious, how many medication doses do you actually miss in a given week? This takes some of the onus, some of the stigma off it, and the patient's less likely to be embarrassed and not say what's going on. So asking it in that kind of way will get you a better answer. Red flags, you have already caught that. Many missed appointments. Unexplained poor control with ordinary medication regimens. Absolutely. You have a patient with the new hypertension and you give them losartan and hydrochlorothiazide, and they come in a month later, oh yeah, I'm taking my meds, doc, and the blood pressure is still 152/98. It hasn't changed. Vagueness regarding medication. Oh yeah, there's the blue pills and the red pills. Inconsistent monitoring of condition for patients, particularly who have been monitoring their home blood pressures or been monitoring their using a glucometer, or I don't know if your patients have access to CGMs for diabetes. I really like them, but that's another issue. If they've been doing it regularly and they stop, if they've been coming in regularly and they stop, then that's a red flag. This is one of the big points of both of these presentations. Before you add a new medication, do your very best to make sure they're actually taking their existing meds. And boy, have I gotten that wrong. I know the algorithm for hypertension. I've prescribed you hydrochlorothiazide and losartan. Your pressure is still not improved sufficiently. I'm adding amlodipine, if that doesn't work, et cetera, et cetera, et cetera. If especially now, some patients take their meds and it doesn't work right. That's universal, but it's just a red flag. And as some of you have also realized, the electronic health record can help. Now, I worked, as Jennifer said at the beginning, from most of my career for Kaiser Permanente, which is an integrated health system. So most of the patients got their prescriptions at Kaiser, and I could not only check prescription records, I could check refill records. So I don't know if you have access to this. Several of you mentioned calling pharmacists, and I don't know if the EHR you use gives you the ability when you're seeing a patient to see when they last refilled the medications, et cetera, et cetera, et cetera. Because, if you can be a detective, and if the patient says, oh, doctor, I never miss one of my pills, and you say, oh, I'm interested how you do that, because this is July 11th, and the last time you got 100 pills was January 13th. How are you making it last? Or something like that. Again, try not to put them on the spot, but to use that material in a way that lets you talk about the question. Review lab and other monitoring studies. If someone said that in the chat, if someone's A1C has been 7.3, 6.9, and comes in with a 9.2, watch out. Review visit frequency. The patient who has come in every 3 months for the past 5 years, and then you don't see them for a year. Ask patients to bring medication bottles or lists to appointments. That can be very helpful too. Someone of you there already suggested that. I have done that. An anecdote that I really enjoyed at the time, though I was tearing out I didn't have any hair then either, but was a patient said, yes, I brought in my medicines, and they had a big paper bag. At the bottom of the paper bag, there were about 100 different pills in about 8 or 10 different colors all mixed together. And I was actually rather pleased because it gave me a sense of how likely they were that taking the medications accurately, even if I thought it was funny and alarming at the same time. Now, the old paradigm about prescribing, and we're going to talk about that next time more, but this is still in the background in many medical settings. Our responsibility as practitioners, we have to make the right diagnosis. You have hypertension, it needs treatment. Write the right prescription. Here's your prescription. Inform the patient, often perfunctorily, of the reasons for our recommendations and arrange appropriate follow-up. So you're going to, take this pill once a day. You're going to check your blood pressure with the blood pressure machine we're giving you daily. You're going to exercise more. You're going to cut out salt. You're going to stop drinking. Okay, got it? Great. Then it's up for the patient to follow through. The terrible adherence rates are partially a consequence of how much this method works. What are the alternative methods? Tune in next week for that. A newer paradigm, the outline of this, is that diagnosis and prescription are just the first of many steps needed to successfully control chronic conditions. Patients need to be educated, engaged in a manner, this is a long sentence, that's respectful. In other words, we don't like to lecture people, put them down. Interactive, ask questions, tailored to what you understand about their educational level, socioeconomic status, and cultural background. We're going to talk more about that next time, how to do that successfully. But in other words, success is an interactive process based on multiple factors, not just on here's your prescription. Second most important statement of this presentation: the doctor prescribes, the patient decides. The doctor prescribes, the patient decides. This is key. If we don't give them the tools they need to make good decisions, they're less likely to do that. And we're going to talk more about that. Now, some other issues that raise concern around compliance. A culture, and by culture, I don't just mean, well, I'm Native American, I'm African American, I'm, South Asian. I mean, culture permeates our whole understanding of the world, and people from the same country or obvious cultures often come from different subcultures with different attitudes and beliefs. This affects how we understand disease, our attitude towards treatments, complementary medicine, communication styles, important one, language issues, really important and difficult one. The greater the cultural gap between doctor and patient, the more likely that cultural issues may impact on treatment. This has not been really well studied, but there are papers that support that idea. So especially if you're seeing patients who come from very different backgrounds than you, different cultural groups, different language groups, it's even more important to understand that you need to come to a meeting of the minds, and that can be difficult. Some other special issues worth watching out for in non-adherence: depression. As we all know, depression is extremely common in various degrees. There's both your full major depressive disorder and there are minor degrees of it, but it's very, very common. It's often undiagnosed. Patients don't like to bring it up, but depressed patients do not take their medications particularly well. Denial, we're going to talk about that. Dependence and dementia. Okay. As for depression, if you have a chance, if your MA can do this, screening with the PHQ-9, can be helpful. Or if you have any questions about whether someone's depressed or for everybody, since it's such a common issue. Denial is a very common defense against stress and adversity. What are the stress and adversity here? You have a chronic illness that's serious. That's a stress. So beneficial. Why is denial beneficial? Well, I think I mentioned to you, I live in the San Francisco Bay Area. I live in Oakland. My house is 1/4 of a mile from the Hayward Fault, which is very likely to have a major earthquake within the next 30 years. And I have gotten my house relatively earthquake resistant. I have earthquake insurance. I've decided I want to stay here. So even though every morning I wake up saying, woo, there was no earthquake last night. Well, I don't, but no point in worrying about it. I've made my decisions. And so let's put it out of mind and go on to bigger and better things. But denial can also be detrimental because it keeps us from doing things that we need to take care of ourselves. And fear can strengthen denial, which is one of the reasons that the old scare them into health, to being consistent with health conditions, doesn't work so well. I see that your blood pressure is still 180/110. You're not taking your medicines. We've talked about this. Don't you understand you can have a stroke tomorrow? Well, all that is true, but if denial is part of what's going on, that you can make the denial worse, and you can discuss denial directly with patients, again, in a non-adversarial, non-confrontative way. A lot of my patients with chronic illnesses, it's really difficult for them. It's hard for them to keep in mind. They use the mechanism of denial to keep from worrying about it. And sometimes that puts it out of their mind too much. I'm curious, do you ever think that maybe denial is playing a role here? Again, you'll do this in your own style and tune, but that ways in which we want not to have the patient feel accused, blamed, attacked, threatened, because those are all deaf to good communication. Dependence, as we all know, alcohol or drug dependence, extremely common, and that either of these can interfere with adherence. I wrote here, I should really update this. Consider asking non-compliant patients about alcohol or drug use. I would change it to continue asking every patient about alcohol or drug use. These are new guidelines that are beyond the scope of this presentation, but and I left the old CAGE questionnaire one, but now the better way to talk about this is to ask people how many drinks, if it's alcohol you're asking about, they have in a given week or in a given day. And I'm not going to go over that, but there are numbers that would raise a red flag about possible substance use disorders. Now, I do swear by this last question: which recreational drugs do you use? What's your favorite recreational drug? As opposed to, you don't use any of those dangerous drugs, do you? Which tends to stifle honest responses. And no, we're not encouraging people to do recreational drugs if we ask about it in a somewhat permissible way. We're trying to start a dialogue and have a good conversation on the topic. Dementia, this is an important one, particularly if someone you've known for a long time. Advantages of longitudinal care and primary care is who's been better controlled and they're older. The control is starting to flag. Think about this. And I have missed this many times because of the fact that it's not apparent, and patients are often socially well preserved. Oh, hi, Dr. Kleinsinger, how are you? How are your kids? ... And I miss the fact that they're getting vague and that they're not refilling their medicines. And so in any circumstance, think of the mini mental status exam is no longer the prime one. The mini cog is the number one because it has even better, sensitivity and specificity, and it's faster. Or the MOCA if it's more complicated. But anyhow, it's worth thinking about this, especially with older patients. If you have any questions about it, look into it because it could be a major factor. So anyhow, the goals of this presentation were to understand the frequency and consequences of medication non-adherence, and talk some about causes and talk some about diagnosing non-adherence. And next week, we're going to talk about tools and strategies for improving medication in our patients. In the interim, if you find this topic interesting, and I hope you do, while you're seeing patients this week, think about this. Ask them more about this. What do you think their adherence rates are? What approaches have you tried to address this? And maybe if you in the next week or so, you encounter some patient where it's obviously an issue, non-adherent, take the extra time to just, if you can, to talk to them non-judgmentally, ask them questions, etc., etc. Try and understand where they're coming from. Try and put yourself on their side of the table. And because that's really, really valuable when you want to come up with solutions to the problem. And by the way, the solutions we're going to come up with are basically in two categories: things that we as clinicians can do and things that other people in our clinics can do to help with this. This is it takes a village. This is not a one-person kind of issue. And I'm fully aware that we clinicians do not have enough time in the day. It's a whole nother topic. There's so many studies of this. Burnout rates are climbing. It's bad in fairly qualified health centers for a whole lot of reasons, et cetera, et cetera. But my point is going to be that investing a little bit of extra time at the beginning will pay dividends to both you and the patient in the future, but we'll talk more about that. Anyhow, that's the end of the formal presentation. Does anybody else have any questions, comments, concerns, etc.? Raise your hand or put it in the chat.
I had a question I put in the chat at the very beginning, but I could say it out loud, if that's okay.
Sure.
Okay. Again, I work with mostly a Latino, Dominican, Puerto Rican population. And I've noticed that I may prescribe a medication and I'm not told that the pharmacy didn't give it or that they only got some of their medications. Like a patient that had H. pylori, so I prescribed the 4 medications she needed. She only got 2, but didn't tell me until another appointment, which thankfully I had made to check on her. But yeah, she just took those 2. And then just another quick example, forget, it was a very important medication for a patient, but there was a prior auth that we have such low staffing. It wasn't processed for, I don't know, a long time. Finally, they sent me the prior auth paperwork, and I'm like, this is like a month ago or something, at least, for the very important medication. Patient never said anything. And I do try to say, please call me or tell me if there's any problems at the pharmacy. What else can I do? Thank you.
Well, you're raising a lot of different questions. Basically, the examples you do are systems issues. The pharmacist who doesn't prescribe, who doesn't dispense the correct medications, the fact that prior authorization request comes in too late to be dealt with, et cetera, et cetera. I wish I had a really good answer for this, but this is one of the reasons we make follow-up appointments. Again, to the extent, if this is a one-off, these things happen. If this is a consistent problem, patients aren't getting the ones, then that might be something worth talking about in a staff meeting. Depending on how your clinics are structured, I believe in interdisciplinary staff meetings in which problems can be discussed between the different specialists, but in the specialties, pharmacy, nursing, clinicians, et cetera, et cetera. But there's many a slip twixt cup and lip, being aware that that's a really, really common problem. But I don't have a simple answer to that, except to be aware of this, and if it's a systemic problem, to try and take it on, and follow-up appointments. Now, I have a question. Why does fear strengthen denial from previously? Well, I'll give you, I'm not a psychologist or a psychiatrist, I'll give you my understanding of it. Denial is a defense mechanism, as I understand it. The whole point of defense mechanisms is to, make us feel more comfortable with the difficulties of life and take things that are bothering us out of our immediate stream of consciousness. And I used an example of good defense denial with my house and the earthquake, but with patients, a lot of times when they're upset or anxious about a condition, the process, I don't know if it's semi-conscious or completely unconscious, it goes out of their mind. They stop thinking about it. And if it's true that they're doing that because they're anxious or because they're concerned, if you scare them, that actually can feed into that process and into susceptible people and make them more likely to just blanket out of their minds. And I'm sure all of you can think of something in your life that has been difficult for you that you don't think about all the time. That denial plays a role. And I'm saying denial is universal, and we have to be aware of it. We have to appreciate it. We have to help our patients with it. We have to recognize it. What can I do? Some patients tell me if there are problems getting meds. That was my question. What can you do? How can you do? Well, I mean, you can tell patients when you see, especially if it's a common problem, like in a FQHC where people can't afford, this is what I'm recommending. If you have any problem with this, please let me know, call me, email me, et cetera, et cetera. If there's a problem, I want to know if there's a problem. It's really important for both of us that you, for example, take this medication, give them that permission, and have systems set up so that they can get back in touch with you. Or your MA, or I don't know what your communication systems are like there. At Kaiser, we have an email system which is robust, and patients use it. In fact, the clinicians are going crazy because they don't get time in the day to deal with the emails, and some of them are getting 20 or 30 or more emails a day. So anyhow, but having good, this would be a systems issue, having good, besides someone actually making an appointment, showing up and putting their butt on your exam room table, having ways that people can get back to you for things like that. Okay. Any other questions, comments, concerns?
Going to add, I wonder if in some respects it's like a cultural thing, because I remember this one, like one patient, he was in the a room waiting to be seen for, I think it was like 2 hours, and it was just some mistake in the workflow that it wasn't registered he was there, but he was just calmly waiting. And then when I finally saw him, he wasn't complaining at all. He's just like, oh, hi, thank you for seeing me. So I wonder if it's also this, like, it's, I don't know, like this just like, okay, well, I'll just wait. I'll wait and see what happens kind of feeling, which I don't think that I have that kind of patience. Regarding why they don't.
Sure. Well, people are very, very different. There's that patient, and there's the patient who has the 1:10 appointment, and you walk in proudly at 1:15. They say, why'd you keep me waiting? but everybody's very, very different about that. And again, the communication, interaction, talking to them, asking them questions will help build a relationship. We're going to talk more about that. Anybody else?
Well, while we wait for some more questions, I just wanted to remind everybody about the CME survey. Just a reminder that it will appear in a tab when you close out of this webinar. So we really appreciate you taking the few minutes to complete it. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers and they greatly appreciate your thoughts. So please fill that out. And I did put all that information in the chat. And I did put some information about education sessions in there as well if you were interested and who to contact.
Yes.
But we
And
do have some more time for questions.
Yeah, I appreciate the feedback too. It helps me. Next week, we're going to talk about how to deal with this. And by the way, anybody who hasn't come, please come, everybody here who finds this interesting, because that's the most meaty part of this presentation. And anybody who hasn't, who might be interested, the second presentation is complete in its own way. You missed some of it, but it could be very useful. What makes you passionate about this topic? When I first started dealing with this patient topic, I was like many of us. I was thinking, what's wrong with these patients? And I was taking the blame the patient, gee, they're just not smart enough to do this or whatever. And then I started realizing that some of my very highly educated patients, were not doing a particularly good job either with this. And I couldn't just assume it's because they weren't smart enough to follow my very excellent advice. And so I started talking to people about it because I was curious. And then I got interested in this and I said, oh, well, this is obviously a problem. Let's look at the medical literature about this and see how to deal with this. And I got a big fat 0 on that when I went into the medical literature. It wasn't being dealt with. Even though I am a relatively obscure, primary care physician, I was not an academic, a clinician most of my life. I have, by dint of being interested in this, become a national authority on medication non-adherence. If you Google medication non-adherence, my articles on this come up in the very top of the list. And not because I'm so incredibly bright or anything like that, just because it's such a neglected topic. And then it's my personal nature that when I see a neglected topic that's important, I want to take it on. I get frustrated by it. So I hope that answers your question about me personally. And I'm looking here. Okay, great. Okay, well, again, and I want to thank all of you for your participation. That makes this presentation, I think, so much more valuable for all of us. I appreciate it, and I hope this can continue for next time. So if we don't have any other questions, comments, criticisms, et cetera, I'm going to say goodbye for now.
Okay. Thank you so much, Dr. Kleinsinger. I really appreciate it. It was a great presentation, and thank you to everyone who attended. Have a great rest of your day.